Great. Thank you very much. And thank you very much for the opportunity to experience some real weather. I think I've only just recovered from the walk 3 blocks here. Right, and I'm the beginning of the fluffy bit of science. So this is the public health and epidemiology. So I've got some acknowledgements and conflicts of interest due to some various grants that funding and some support from pharmaceutical agencies. And I've taken a few slides out actually because I wanted to try and be quicker than the time allocated so that I know you're very polite, so give an opportunity to discuss or for other presenters to have more time. And I want to talk about the epidemiology of the prevention of hepatitis C, and I'll present some old models and some new models that are in press, and also some empirical data on transmission risk reduction. And that all relates to opioid substitution treatment and needle and syringe programs. And it's important to remind ourselves that that's where the data exist in terms of transmission risk. The information I'm going to show you about the impact of HCV treatment is all from models, fantastic though they are, but they're all about raising the hypothesis of treatment as prevention. They're not testing it. Okay. So thinking about, there's good data now emerging on the impact of opioid substitution treatment, methadone, buprenorphine, or high coverage needle exchange on reducing transmission. So either of those, and what we call high coverage needle exchange is where people have got about, on average, 1 syringe per injecting frequency, for the amount of times that they inject. And this is from pooled data in the UK, where transmission is halved if you're on high coverage needle exchange, or if you're on opioid substitution treatment, and reduced by 80% if you're on both of those. And we've got this data will be coming out soon. We're doing a Cochrane, a review for Cochrane, which I'll never do it again for Cochrane, because it's, even though I'm on the editorial board of Cochrane, it's just a nightmare. So there's good international evidence now emerging that opioid substitution treatment reduces hepatitis C transmission. So this is real studies, admittedly mostly observational, but again here we find the synthesized effect of at least a 54% reduction. And I say at least because there's a sort of bias in many of these studies to not include people who are on opioid substitution treatment who are not injecting, because they're usually picked up in studies in the community. So actually, it's probably more than a 54% reduction if you're on opioid substitution treatment. And we've also got some evidence from needle and syringe programs, high-intensity needle and syringe programs. And I show the data here from Europe, which suggests a 61% reduction. There are data from North America, but I didn't want to be lynched when I put those up because they don't look very good. And I keep on being told that we've got the wrong numbers. So until I get the right numbers, I don't want to show them. But again, there are studies suggesting that needle and syringe programs, intensive exposure to needle and syringe programs can reduce transmission. So a couple of years, or 5 or 6 years ago, then the response from most policymakers in Europe, WHO, etc., was to say, well, okay, you've got this evidence, why don't we just scale up? Let's do more opioid substitution treatment, let's do more needle exchange to try and reduce transmission. And so one of the first models that we produced simulated HCV transmission, a population of injecting drug users with a baseline hepatitis C, and then follow them up transitioning between high coverage needle exchange or opioid substitution treatment, and then projected, well, what would be the impact on hepatitis C prevalence if we increased OST and needle exchange? And so this is parameterized for the UK, and it's probably similar to some of your cities in Montreal, not Vancouver, but maybe Montreal, in Canada rather. So you've got hepatitis C, chronic hepatitis C prevalence is about 40% in the UK, and the coverage of opioid substitution treatment and high coverage is about 50%. Now, if we remove it, if we take away OST and NSP, then there will be a rebound of hepatitis C among injecting drug user populations. It will go back to nearly 70% chronic infection, over 80% antibody, which is what it was like in the early 1980s. But if we increase from 50% coverage to 60% coverage, as shown in this figure and with little red dots, we find very little impact. And this is over 10 years on prevalence. And only if we increase from 50% coverage to 80% coverage over 10 years will we get some kind of impact, more substantial impact on chronic hepatitis C prevalence. So, and that is probably unsustainable. You just can't get people into OST and high coverage NSP for 80% of the time for over 10 years. It's probably not going to happen. So that's why we then focused on hepatitis C treatment. So I'm going to present a few models. This is one of the earliest, always the best. This is our old first model. And again, what it does is it simulates a population of people who inject drugs, and then they have a baseline prevalence of hepatitis C, and then then we introduce hepatitis C treatment, and then we project, well, what impact will it have on prevalence over time, over 10 years or whatever. And we do it in different populations where chronic hepatitis C might be 20% or 40% or 60%. And then we extended that model also to track hepatitis C, not just hepatitis C transmission, but also progression from mild disease to moderate disease to severe disease and other consequences. And we also look at the populations of people who inject drugs, but also ex-injectors or non-injecting drug users. And we assume for that population, people who have ceased permanently or never injected, that there's no transmission risk, no reinfection risk. But obviously, it's a dynamic model. So what we do is we also track reinfections, but critically, we track what happens to the prevalence over time. So as you treat people, you get a prevention benefit. You prevent onward transmission of hepatitis C. And then we can add money to this and estimate what's the cost effectiveness of different options, which I'll show you. So this was one of our oldest slide, or not oldest slide, what am I saying? One of our original models. And this is for pegylated interferon and ribavirin. And it's interesting, we're all talking about direct-acting antivirals, which are fantastic. There's a bunch of health economists in the UK are still trying to promote interferon, which will be based on cost effectiveness. But anyway, I'm not one of them, but it won't go away. So this shows for those three scenarios, 20%, 40%, 60% chronic hepatitis C, that as you scale up the amount of hepatitis C treatment, whether it's 5 per 1,000 injectors or onwards to 40, you can get substantial impacts, especially in those populations with lower prevalence of hepatitis C. So we then also looked at, that's just looking at interferon, ribavirin, so then we want to look really at the new treatments, and we also want to combine interventions, so not just look at hepatitis C treatment, but also look at, well, what's the impact of opioid substitution treatment, needle exchange. So here, this is like a sort of heat tech, but it's more of a sort of, it's not so sexy as the sort of genetic transcriptomic ones. It's more of a little figure that, so on the x-axis, you've got the increasing the coverage of opioid substitution treatment and needle exchange, and on the y-axis, the vertical axis, you've got increases in hepatitis C treatment. And each of the topography or the lines shows the percentage reduction in hepatitis C over 10 years in a population where you've got 40% chronic hepatitis C. So you can move with very little introduction of treatment or opioid substitution treatment, needle exchange, you get very little effect, so where it's dark red. Then you can move to as you scale up, you could get a 50% reduction in orange, and then you can get to the nirvana of near elimination in white, where it's going over 80% or 90%, in theory. Now, what's interesting about this figure for us is that there's two things. One, that if you want a substantial reduction in hepatitis C, say you want to reduce it more than 40% over 10 years, so you have a real impact, you've got to have hepatitis C treatment. You cannot just rely upon opioid substitution treatment and needle exchange alone. You can if you want to wait 20 years or longer, but if you want something relatively soon, then hep C treatment has got to be delivered and scaled up for injecting drug user populations. But equally, because these lines are not flat, they're sort of angled, as you scale up opioid substitution treatment and needle exchange, you need fewer treatments in the population to achieve target reductions. And so opioid substitution treatment and needle exchange can conserve your expensive treatment therapies and also increase the benefits of treatment in terms of prevention. So our next series of we're interested in is looking at, well, which patients should be treated or which prioritized. And it's very interesting in the real world. I mean, it's fantastic, the real world examples, that most of those real world examples aren't people who inject drugs. And in 2014, the guidance from EASL and probably ASLD as well. I don't know, I mean, you're North American, so presumably, do you do ASLD? Is that US? Anyway, you're not European, so. Or you were European, but anyway. So in 2014, it was all about recommending treatment in terms of severity of disease, so targeting people with cirrhosis or moderate disease. And then in 2015, they suddenly said, well, hey, let's prioritize people who've got an injecting risk, a transmission risk, such as people who inject drugs, and that you could recommend treatment to these populations irrespective of their fibrosis stage. But they also noted that the evidence was pretty moderate, in fact, you might say pretty poor for that recommendation. There's not very much evidence, but it sort of seems to make sense. And we wanted to look at sort of some models that look at that. Now, first model that we've got coming out soon in Journal of Viral Hepatitis was we were interested in looking at what's the impact of what in the UK, because they are going by disease stage, so they're really scaling up treatment for people with decompensated. That's all been done now. It's on the compensated, or cirrhosis, and then moderate disease. And on what this shows is the importance of that. So the grey line is the number of people, or the incident cases for end-stage liver disease and liver cancer, and showing that at current treatment rates, or prior to 2015, they weren't high enough to actually reverse this increasing trend in liver morbidity. And so, but if you scale up treatment to people with cirrhosis, you can have an immediate impact. Now, what this model also suggests is that you also need to start scaling up to people with moderate disease, otherwise you'll get a little bit of a rebound back to end-stage liver disease. But if you start targeting people with mild disease, you're going to have no impact whatsoever in 15 years on end-stage liver disease and on liver cancer. So the benefits of treating people with mild disease is all about, well, you might think, is all about prevention benefit, which I'll go and show. So we wanted to also look, and this is coming out in hepatology soon, looking, well, I think it is, yes, it is. Looking at treatment prioritization, because one thing that you could do, and NHS England, because it likes to, we're in a sort of austerity world. You could argue that actually, why don't we just delay treatment until people have got later stages of disease? Why bother targeting? I mean, we will soon run out of people with F4, F3s, but you could say, well, let's just wait until they get F3, or which patients should we then prioritize? So we did a model which then trying to assess where the decision was, do I delay treatment until severe disease, or do I treat them early? And we wanted to compare people who inject drugs with ex-users or non-injecting drug users in 3 different scenarios, in where chronic hepatitis C in the population of injectors, drug users, is 20 or 40 or 60%. Our drug costs, we're assuming 12 weeks and about £30,000 a course, which is what, $50,000 or something like that, Canadian dollars. So, and an SVR of 95%, and we then we treated for 10 years, and then we sort of tracked it over 50 years. And what we wanted to do, and what we did was we ranked prioritization by what's called net monetary benefit. And net monetary benefit is the mean incremental quality adjusted life year times the willingness to pay threshold. And the willingness to pay threshold for us is, how much you're willing to pay for each additional quality adjusted life year. And it was about £20,000 in the UK, so $30,000, $40,000 in Canada. And a negative net monetary benefit suggests you delay treatment. And the prioritization is that you prioritize the patients with the highest net benefit first, and then you go to the next one. So that was the analysis. And I'll show you for the 3 different scenarios. So here we can see from the 20% chronic hepatitis C scenario that there's massive net monetary benefit for prioritizing early treatment to people who inject drugs because of this prevention benefit, both with mild disease and with moderate disease. And this pertains also for populations where chronic hepatitis C is 40%. Again, the 2 patient groups you would prioritize first would be people who inject drugs with moderate or mild disease, before then moving on to other patient groups with moderate disease who haven't got a transmission risk. And in fact, at the cost of £3,000 per week, the cost effectiveness or the net monetary benefit was less than naught for people with mild disease. So you would delay treatment for people with mild disease who didn't have a transmission risk. And it's only in populations where you've got very high prevalence of hepatitis C, 60% chronic or more, that the key patient group you prioritize first would be non-injectors with moderate disease because of the high rates of reinfection experienced by people who inject drugs. And, oh yeah, good. It does say something. Now, importantly, the net money benefit, even if you change the cost of the drug, so if you reduce the cost of the drug, then actually the net monetary benefit will become positive for people with mild disease. It will become cost effective to treat those people with mild disease compared to not treating them. But the relative rankings will stay the same irrespective of the cost of the therapy. So in terms of the rankings, so from an economic perspective or from a public health perspective, you would prioritize people who inject drugs in most populations, except for where chronic hepatitis C is over 60%, which might be an uncomfortable, it isn't an uncomfortable conclusion for some clinicians, but I'm a public health specialist, so I think it's fantastic. This gives an idea of the estimate of the prevention benefit. So in populations where you've got 20% chronic prevalence, for every person you treat, you're going to reduce another 2 infections over time. So you treat a person who injects drugs with mild or moderate disease, another 2 people will have their infection prevented. And where you've got slightly higher prevalence of hepatitis C, 40%, again, you treat 1 person, you'll get another 1 infection averted. But obviously, when you've got very high rates of reinfection, then the prevention benefit is very low. There are other benefits of early treatment, and that is in relation to and unfortunately, I'm sorry about this figure. This is one of my slides that I haven't persuaded someone else to make nicer. That if you treat early, you do prevent end-stage liver disease and hepatic cellular carcinoma, because the later you treat, although you'll sort of reduce the number of infections, there's still an ongoing transmission, or not in transmission risk, but there's an ongoing potential of developing later consequences of liver disease. So what this shows is for people with moderate disease, in those populations with 20 to 40% chronic hepatitis C, that again you can reduce the number of end-stage liver disease or liver cancer of about 0.08 per year, so over 50 years. So in other words, if you treat 12, 13 people, you'll prevent one further case of end-stage liver disease over 50 years. But if you treat people with mild disease, you get much less benefit because many people you treat with mild disease won't actually go on to get end-stage liver disease. So one of the things about treatment as prevention is well, should we just wait around and see what's going to happen? So in other words, are people treating at a high enough rate in the population so that we can then wait around and see the results? So it's very difficult trying to find out how many people injecting drug users are being treated. So we've done some work with, this is 11 countries going from Amsterdam, Belgium, Czech Republic, Denmark, Finland, France, I won't go through them all, up to Sweden. And this shows the treatment rates per 1,000 injecting drug users in those populations. It shows two things, I hope, to show. One is the variation in treatment rates that are going on in different countries. So Finland is a bit embarrassed. They realized that they weren't treating any people who inject drugs. France are treating more, but what the uncertainty is in relation to the number of people who inject drugs. So they're very uncertain about how many injecting drug users there are in the population, certainly more so in France than many of the others. So this sort of range is primarily due to uncertainty in what the size of the population is. Now what we can do is then we can model, well, what's the impact of those treatment rates on chronic hepatitis C prevalence over time. So this shows again for those 11 sites, and this hopefully will be coming out soon. And in blue, this is our baseline chronic prevalence of hepatitis C in the sites from Amsterdam to Sweden. And again, it shows the variation in chronic hepatitis C in these different populations. So we've got places which have got nearly 20% or less, such as the Czech Republic or Slovenia, and in others where it's 50% or more, such as Amsterdam and Finland and not Hamburg, but and also Sweden, and there are many others are between 40 and 50%. So this is variation in chronic hepatitis C in the population. There's also, again, uncertainty. They don't really know what the level of chronic hepatitis C is among the people who inject drugs. So, but when we go from the blue to the green, so that's when we sort of track, we say, well, okay, over 10 years, given your current treatment rates and you're now using these fantastic new therapies, what impact will you have on chronic hepatitis C? And in most cases, it is very unlikely that you're going to observe a difference. You won't see, the treatment rates are too low. The Czech Republic like to say that they might be able to observe a difference, but I think it's sort of 50-50. Their data are not that good, really. There's no one here from Czech Republic, so it doesn't matter. But it's very unlikely at current treatments. Only if you start to double treatment rates or increase them even more further that you'll start to potentially observe a difference in the population. So, am I okay for time? I can stop now. I'm going to stop. Oh, well, after this slide. So, the theory and modelling have shown, I think, hopefully, that hepatitis C treatment, we think, is critical, and I think you will acknowledge that it's critical for hepatitis C prevention in people who inject drugs. I've didn't show you some other slides on cost-effectiveness models of case finding, but introducing and scaling up hepatitis C case finding in injecting drug user populations, whether in the community or in prison, is cost-effective, primarily driven through uptake of treatment and the prevention benefit. An early treatment of people who inject drugs is cost-effective and probably these patients should be prioritized in populations where chronic hepatitis C is less than 40%. We've also shown in our studies, some of the data here, and it's probably similar data in North America, that probably current treatment rates are unlikely to lead to any measurable observable change in hepatitis C transmission, the treatment rates are too low, and there's too much uncertainty around many of the parameters. But do remember that we shouldn't neglect opioid substitution treatment needle exchange. That's where the evidence base is, real evidence base is at the moment of transmission risk reduction. What I've shown you, hopefully, is that we've got now good, repeated evidence of showing that it is worth looking at hepatitis C treatment as prevention, but it's an hypothesis that now needs to be tested. We can't wait around for it'll suddenly emerge miraculously, because it won't. It needs to be investment. We need to scale up treatment for it to be emerged. So I would rather we start to look a bit more closely. In fact, it's a bit embarrassing, isn't it? It's like researcher says there should be more research on hepatitis C treatment as prevention, because we're not going to see it otherwise. Thank you very much.
Thank you, Matt. Is there any questions?
No.
Jason, please.
So a really nice talk, Matt. A concern that continually sort of gets pushed around is the whole issue of reinfection and reinfection rates. And I was just wondering on sort of if you could comment on sort of reinfection post-DAA therapy and what your views are on that.
If people don't get reinfected, then you're not treating people who've got a transmission risk. I mean, that's just going to happen. So the balance is between what the reinfection rate is versus how many people have actually prevented onward transmission. So I'm not that bothered about reinfection. It's annoying because the drugs are so expensive, but apart from that, it's not a problem. We're not so good at the moment about detecting the prevention benefit. The trouble is, if you treat very few patients, you won't see the prevention benefit. All you'll see is the reinfection, so it'll look bad. It's only when you start scaling up treatment that you'll see a bit more reinfection, but also you'll see the prevention benefit. That's the problem.
Next question.
My name is Maurice Sherman. I'm chairman of the Canadian Liver Foundation. I have a comment, and that is that your talk and most of the meeting today has been focusing on a very small population of hepatitis C infected individuals, namely the people who inject drugs. The much larger population, of course, is those who are not currently using. They may have acquired the disease that way. Or in Canada particularly, it's the immigrant population that's a fairly large cohort. Yeah. And if we look at the overall prevalence in that population, it may be up to 1%, but certainly not more than that.
Yeah.
So my question, I guess my comment is that I see this group to me as being ignored, not just in this meeting, but generally being ignored. And the question is, have you done any modeling looking at those very low prevalences?
Right. Okay, so in the UK, 85%, 90% of chronic hepatitis C is among people who inject drugs, who are current users or ex-users. I agree, there is an increase of hepatitis C among other populations, such as migrant populations and men who have sex with men, especially if they're co-infected with HIV. So I think our interest in people who inject drugs is more around the evidence for what's the evidence for using it as for prevention. We do model other populations, and in particular people who acquire hepatitis C through unsafe blood products, which is a really important source and the greatest source in developing countries, as well as among men who have sex with men. It's just that the focus of this is all about treatment as prevention. But I quite agree that there is another population group. The trouble is that the decision for treatment is pretty obvious. If you haven't got a transmission risk, it's based on disease severity.
Thank you very much.
Yeah.